lucky to be joined by Dr. Harold Adams, who has been a professor at the University of Iowa. Dr. Adams has had a distinguished career of over 50 years as a clinician, researcher, and teacher, and we are so grateful that he continues to take time out of his day to teach and speak with us about his experience with outcome measures. So today his talk is titled "The Use of Clinical Scales in Stroke: Implications for Researchers and Clinicians." And I will share the slides.
Thank you very much, Megan. I turned off my video so you can focus more on the slides. In case some of you don't know, I am a professor emeritus. I retired 5 years ago. About 10 years ago, I had a spinal cord injury, which limits some of my mobility and activity. And so you may not see me at meetings for obvious reasons. What I'm going to talk about in the next few minutes will be the use of clinical scales. I'm going to talk about ischemic stroke, but the same things I'm going to talk about with ischemic stroke will also play a role in other areas of neurologic research. And why don't we go on the next slide? I have no conflicts of interest. I'm not getting money from anybody. Sometimes I wish I was, but I don't. All right. Now, so we're going to focus on ischemic stroke, acute ischemic stroke. Similar issues will be found in using clinical assessment instruments in other studies of neurologic disease. So if you're doing studies in Parkinsonism or multiple sclerosis or some degenerative disease, the same issues that we have had and faced in stroke will be there. I am been doing this for 40 years, and I remember being on study section at NIH and realized very quickly how stroke and the problems that we ran in doing our assessments were the same that the other subspecialties in neurology had. Let's go on the next slide. So why is this process important? Well, we know that evidence-based medicine has changed the management of patients with all neurologic diseases, including stroke. Guidelines, which I helped develop in stroke many, many years ago, now provide the foundation for evidence-based medicine and have created the standards of care. The information to form these guidelines comes largely from modern clinical trials. And not only do clinicians, but third-party payers and regulatory bodies depend on the results of these clinical trials. Several years ago, I was on an FDA advisory panel and voted to recommend the FDA approve the use of thrombolytic therapy in treatment of acute ischemic stroke. Similar things have come along now with improvement of endovascular therapy, etc. Next slide. So now in modern times, the management of ischemic stroke is being stimulated by research funded by NIH through the NINDS StrokeNet program. It has three major areas of research: prevention, acute treatment, and recovery and rehabilitation. All three of these areas are equally important. Next slide. So what are the issues? Well, in prevention, obviously the goal is to prevent stroke or recurrent stroke, and indirectly reducing mortality and all the problems. The best treatment of stroke is to prevent it from happening in the first place. The acute interventions are aimed at limiting the severity of the brain injury and or prevent medical or neurologic complications that occur with the injury, such as hemorrhagic transformation or brain edema or seizures or bed sores. Recovery involves obviously physical therapy, occupational therapy, speech pathology, other efforts to maximize the recovery and limit the neurological sequelae so a patient can be able to return to society with limited problems with handicap or disability. Next slide. Now, There are several problems in designing trials in acute ischemic stroke. One is there's a broad spectrum of vascular diseases. Two, there are tremendous variations in the extent and location of brain injuries. Injuries to the brainstem present with different problems than those of the cerebral hemispheres. Problems in the dominant hemisphere act differently than those injuries in the non-dominant hemisphere. There are epidemiological variables and serious comorbid diseases, hypertension, diabetes, cancer, and we have multiple concomitant therapies that may involve or impact on the patient's status. One of the areas of receiving a lot of interest at present is the whole relationship between cancer and stroke, because this has become quite clear that stroke doesn't cause cancer, but cancer causes stroke, and all the variations of the things that may occur in this group of patients. Next slide. Now, there's been an attempt, and there are in other areas of neurology, attempts to use surrogate markers. This has some limitation. Imaging can be done to see the size, location, and evolution of a stroke. It could be an MS plaque. You can do functional brain imaging. Obviously, in endovascular therapy, it's recanalization. We have biomarkers that may be useful. However, as of now, at least in ischemic stroke, there's no surrogate marker that substitutes for the clinical phenomena. It makes no sense to go to the FDA and say, well, we have a much higher rate of recanalization with this intervention, but it made no difference in how the patients were at the end. That's not going to get, that does not provide very compelling data to the FDA to want to do something. Next slide. So that leads us to rating instruments or stroke scales. These are used not only in research, but are also in practice. And these are similar scales can be used in any neurologic disease. They can assess the types and severity of neurologic impairments. They can be used sequentially to monitor for changes in neurologic status. Obviously, the findings on the scale will influence decisions about both acute and long-term management. Also, you can see if the patient's improving or deteriorating to assess responses to treatment, and they can also be used to determine outcomes. Next slide. Now, for a clinical rating instrument in stroke or any other area in neurology, it must be credible. It has to be germane to the clinical situation. We want an instrument that is widely used and is clinically useful. The results of the scale and scoring must be believable and make sense to both healthcare providers and the public. In short, a knowledgeable person should have an image of a patient's status when given the score on a stroke scale. We do the same thing with head injuries. If somebody comes in with a head injury and has a Glasgow Coma scale score of 13, you know they're not so much trouble. But if they come in with a score of 6, you know this patient has a high degree of likelihood of having a severe incapacitating, life-changing injury. Next slide. So, how do you develop a clinical rating instrument? I'm going to try to dissuade you from taking this process on. You have to consider what is the purpose of the scale and how will this information be useful. It has to be generally relevant to the assessment of patients with stroke. If you're doing a scale for Parkinson's, it has to be relevant to patients with Parkinson's disease. Generally, clinical rating instruments are based on the patient's performance. You can add items by history or exam or even ancillary diagnostic studies, but the more different components of the scale, I frankly think weaken the scale. And a good way to remember is focus on the patient's exam. Next slide. So you want a scale that is easy for patients and assessors. I don't know if any of you have ever used the Fugl-Meyer score in assessment of patients with residuals after a stroke or other neurologic disease. It takes 45 minutes to do the assessment. By the end of 45 minutes, both the patient and the examiner are tired. I will tell you, when I ask our coordinators about doing the Fugl-Meyer score, they run as far away as possible from the scoring because it's so difficult. You want to have clear instructions for use of the scale and how to score it. It should have good inter-rater agreement and that the same rater will get the score or close to the score at the same time. These are not minor issues. That means that you have to have a certification program or educational program for it. When we first started our clinical trials at the University of Iowa, we developed a certification program. We'll talk about it a little bit more when we talk about the NIH stroke scale. But it took time. There was one thing that we did in our study is that yours truly ended up doing diagnoses on all 1,300 patients in our one clinical trial. So I reviewed the etiologic data in all 1,300. I may have been consistently right or consistently wrong. But anyway, I tried the best I could. Next slide, please. Now, when you get to a clinical trial, which most of you want to do, remember there are extra requirements. You have to assure your colleagues, the public, regulatory bodies that the scale was done correctly, that the scoring is accurate and consistent. You want to use a well-validated scale that can be, your results can be compared with other research programs. Actually, the NIH and other funding agencies and the regulators will demand that. And then in a clinical trial, you have to have a program to be sure that the scale is being reliably and reproducibly tested. This means you either do education and certification and then possibly central adjudication. We were involved in a clinical trial in stroke where we had to videotape our final exam and send it to Scotland for them to do the modified Rankin scale at the end. And all their scores are the ones that were used in the final analysis. Next slide. Now, many of you are young and excited and want to develop your new clinical rating instrument that you can use. Now, as you see, I have a dead end sign here because this is time consuming in itself. When we developed the NIH stroke scale, it took us almost 2 years. And then when you get done, it may not work. This delays your primary goal of your project. I would suggest either adapt the current scales or adopt verbatim the current scales to use for your research. Next slide. All right. So now, how do you develop a clinical rating instrument? This can be based on history or direct exam. As I mentioned, some people will have diagnostic tests included. Generally, there are 2 types of scales. Numerical scales, where there is a total of components that are each scored individually, and then the scale is added at the end, or a single score scale, which is based on the aggregate of all information rather than individual items to be assessed. All right, let's go on to the next slide. Now, when you have a numerical scale, there will be several components that will be assessed and scored individually, and then the scores are added up to give a total scale, the score. This may represent a combination of different items. Depending on the scale, a high score can be good or bad. For example, the NIH stroke scale is a classic numerical scale. Next slide. A single score is all components of the assessment are summarized into a single score. And they will have specific and defined criteria. With these scales, generally, the higher the score, the poorer the situation. An example would be the modified Rankin scale. Next slide, please. Now, in addition, there are modality-specific stroke scales that are most commonly used in rehabilitation and recovery research. These scales often emphasize recovery or compensation in a specific activity, such as language or walking or hand function. These scales, while very useful in rehabilitation or in that individual setting, may not provide an overall assessment of the patient's autonomy. One of the things that has happened in post-stroke rehabilitation is there are a huge number of scales that are rather idiosyncratic and are very difficult to use in other rehabilitation settings. So if you're going to be looking at rehabilitation, this is going to be a quagmire as you move into your research. Next slide. All right, so we have global measures of outcome after stroke. These are generally well accepted by the medical community, the NIH, and other governmental regulators in the United States, in Canada, in Europe, throughout the world. These generally divide favorable versus unfavorable outcomes. For example, with the Rankin score, a score of 0 or 1 is generally favorable, maybe 2, maybe rarely 3, and the higher scores are going to be considered unfavorable. And these will measure the impact of the event on the patient's outcome. Now, they may miss important neurological issues, such as discrete areas of neurologic disability. You can still get a very good score and still have problems with some components of recovery. One of the scales that's used in rehabilitation, you have a score of 100 points, and to be a favorable outcome, you get 90. Well, that doesn't give you much room in between. All right, these scales often require, measures require a larger clinical trial to demonstrate efficacy. Next slide. Now, the modified Rankin scale is now the standard for measuring outcomes in patients with stroke. It does provide an emphasis on motor and walking. Healthcare providers, nurses, coordinators, physicians, everybody can do this scale. And most people understand now what the scores of the Rankin scale mean. So if you're doing acute stroke research or stroke recovery research, I suggest you keep using the modified Rankin scale. There's been nothing else that's come along that's really much better. Next slide. Now, when measuring neurologic impairments, there are several goals from this. One is assessing the baseline severity of stroke. There is no single predictor of outcome that is superior to knowing how bad the stroke was at the beginning. So the higher the NIH stroke scale, the poorer the prognosis. I'll go over that in a couple minutes. It provides information about treatment. It also will allow with sequential measures to see if the patient's getting better or worse. The NIH stroke scale is now the classic measure to assess neurologic impairments. And we were involved with this back 40 years ago now in our initial studies with NINDS. Next slide. So the NIH stroke scale has 15 items on the neurological exam. Each item is scored independently. And you come up with a score of 0 to 42. I point out that the NIH stroke scale is like golf. You want a low score. This is not NBA basketball. You want a low score. Higher scores, more severe stroke. Next slide. When we first assessed the NIH stroke scale, we found that there was a high inter-rater agreement and retest reliability. We also showed that there was a strong correlation with the score on the NIH stroke scale and findings on CT, as well as outcomes at 3 months. So now the NIH stroke scale is used internationally in a wide range of stroke research. Next slide. Now, what we have found is that the total score is important. Now, if we had thought when we developed the scale that a numerical score would predict outcomes as robustly as it did, we would not have come up with a scale that has 0 to 42. We would have had something maybe to 100 or 50 or something else. But what we do know is that the lower the score, the milder the patient is. And so if you get a 20 or above, your chance of a very favorable outcome without intervention is around 3%, or 97% chance of being dead or disabled. There was some recent studies looking at interventions after rehabilitation to use stimulants to help maximize recovery. Well, they showed no benefit. Well, they enrolled patients with a mean NIH stroke scale score of 3. They're going to get better despite what we do, not because of what we do. Next slide. This is some research that we did based on one of our large clinical trials. You can see that as the number of points add up, the chances of an excellent recovery drop rather dramatically. Frankly, between 5 and 15, I call that the double black diamond slope in Colorado, because you're going downhill really fast. And so that if you look at some of the modern interventional trials, they are emphasizing those patients that have scores of 15 and above, because that's where we end up with these devastating multilobar infarcts that are associated with very poor outcomes. Next slide. So now there are advantages of the NIH stroke scale. It is it's a well-validated measure that can be performed by nurses, EMT professionals, physicians, everybody. There's high inter-rater agreement, etc. One of the things is it can even be done by telemedicine, and it has now become the lingua franca for acute stroke. So that if you say some doctor in a community hospital calls you and says, I have a patient who has such and such impairments, and you put together a score that comes out to 15, for example, you know have a patient that has a moderately severe stroke and needs to be treated as quickly as possible. Next slide. There are some disadvantages of the NIH stroke scale. It is biased towards the dominant or left hemisphere. This is related to the big impact of orientation and commands, which are linked to language. So that if you have aphasia, you may not be able to answer the orientation questions or necessarily follow the commands, and you get 4 or 5 extra points very quickly. There can be some differences among raters. There are some problems on some components of the NIH stroke scale. The limb ataxia one is hard. Determining how severe a facial weakness is difficult. And the severity of aphasia also can be problematically assessed among raters. So there are some areas where we do still have some disadvantages of it. Next slide. We've done a variety of ways to try to improve this. And if you are involved in stroke research, you have found out about this already. We have a certification process, which are available at several websites from NINDS, from the American Heart Association and other groups, to go through testing and remediation. And then the other way, of course, is central adjudication of the scores. So as you can see, these programs have been around for 30 years, but still remain important. for ongoing stroke research. Next slide. So there have been attempts to change the NIH stroke scale. So far, these have not been very successful. The score is now an entry criteria for trials and selection of interventions. It is used, as I mentioned earlier, in interphysician communications. And I do not see the NIH stroke scale being replaced by any other clinical severity measure. It's so ingrained in stroke research that I think we are going to be using it for a long, long time to come. Next slide. Now, let's change topic. Ischemic stroke is due to a wide variety of medical diseases. The cause of the stroke influences both acute and long-term prognosis and has a major impact on the care of a patient, including prevention of recurrent stroke. In addition, besides the healthcare providers, patients and families want to know why the stroke happened. Is it just bad karma, or is there a reason that it happened? Hardening of the arteries, cardiac event, something else that leads to the ischemic stroke. So you have to be Sherlock Holmes as you determine the cause of the stroke. We just don't say bad luck. Next slide. So if we accept the categories of ischemic stroke, we have large artery atherosclerosis, both extracranial, such as the carotid bifurcation or vertebral artery, or intracranial with involvement of the middle cerebral artery, posterior cerebral artery, etc. Small artery disease or lacunes with the small penetrating arteries going to the basal ganglia, thalamus, brainstem. You have cardioembolism, obviously, as the name implies, an embolus arising in the heart and going to the brain. Obviously, atrial fibrillation being the poster child for that category. We have non-atherosclerotic vasculopathies, diseases other than atherosclerosis that lead to a stroke. This could be vasculitis, or it could be non-inflammatory, such as an arterial dissection. There are some genetic diseases that predispose to ischemic stroke, for example, Fabry disease, or it can have following trauma. We have disorders of coagulation that promote thrombosis. These can be genetic, sickle cell disease, lupus anticoagulant can be an acquired one. So there are varieties. And then we end up with the categories as we don't know what it is, sometimes called cryptogenic, or now ESUS, embolic stroke of undetermined source. Next slide. Now, when you classify causes of stroke, you're going to involve some lumping and splitting. And I've had debates with colleagues about this. If we define patients very carefully after an extensive evaluation, we'll end up as a very homogeneous group of a small number of patients, almost a case report. So if you're going to take only those patients with stenosis of the middle cerebral artery on the left side who come in with non-fluent aphasia and mild right hemiparesis, that sounds like a common condition, but when you start looking for them in a research study, the numbers get quite small. On the other hand, if you take patients with similar findings, you do some lumping, you'll end up with less homogeneous but larger numbers, and those are usually needed for statistically valid research. So if you want to be a splitter, that's fine. If you want to be a lumper, that's also fine. Frankly, I think some of both needs to be done. Next slide. Now, when we developed the TOAST study back 30 years ago, we developed a phase 3 trial testing emergent anticoagulation and treatment of acute ischemic stroke. As part of that, we went on a review by NIH. They required that we develop a system to assess responses by stroke subtypes. We reviewed and built on existing symptoms a classification system for ischemic stroke that I'm going to go over here in a minute. We tested this classification for reliability and reproducibility, and it is now widely used for this aspect of stroke research. Next slide. So the TOS classification is based on the features of the stroke, whether it's cortical or deep, epidemiological factors such as risk factors, hypertension, diabetes, hyperlipidemia, results of the brain imaging study. If there's a small little infarct in the basal ganglia, it's probably not going to be classified as large artery atherosclerosis. The results of vascular and cardiac imaging studies, echocardiograms, CT of the heart, CTA, MRA, and results of other ancillary studies, such as testing for lupus anticoagulant or antiphospholipid antibodies. Now, when we developed this 30 years ago, it was based on diagnostic studies available at that time. Obviously, since that time, new diagnostic studies have become available, but these new studies can be built very easily into use in the TOS classification. So a modern CTA can greatly expedite the use of this classification system. Next slide. So we ended up with some lumping and splitting. We tried to use a system that a physician would think and how they would affect his or her decisions in management. We wanted a scale that would be valid and would make sense to both researchers and clinicians. And we developed definitions for the subtypes. Next slide. So the system that we developed was 5 categories: large artery atherosclerosis, small vessel lacunar disease, cardioembolism, stroke from an other demonstrated cause, such as a non-atherosclerotic vasculopathy or prothrombotic disorder, and an undetermined cause. And there are 3 reasons it can be undetermined. One is the evaluation was not done. A patient came in with a major stroke and died. We did not get an autopsy and never had much of an evaluation. Or a patient had 2 or more causes. A patient comes in with a lacunar syndrome, but also has ipsilateral high-grade carotid stenosis and atrial fibrillation and a prothrombotic disorder. And then finally, the last one was no cause was found despite the evaluation. When the TOS classification is criticized, and it is, and I understand that, there's some lack of knowledge of how the category of undetermined cause combines 3 different groups of patients. Next slide. So when we get to that, there is some degree of uncertainty in all stroke subtype diagnoses. The physician will make the diagnosis based on clinical judgment on available data. And as I've already said, neither doctors nor patients like the diagnosis of stroke of undetermined cause. So we put in 2 criteria, and it was probable diagnosis. We have evidence supporting the diagnosis and lack of evidence to support alternative diagnoses. A possible diagnosis would be evidence supporting a diagnosis, but evaluation for alternative diagnoses not complete. So, for example, a patient comes in with atrial fibrillation and a presumed cardioembolic stroke, but nobody looked at the vessels in the neck or base of the brain to find out if there was atherosclerotic disease. Next slide. So we looked at interphysician agreement. We did this back 30 years ago. We found out that physicians often disagree on subtype diagnosis. They did best with cardioembolism and large artery atherosclerosis. And we also found that physicians don't like to diagnose cryptogenic stroke. Surprise, surprise. Next slide. Now, there are advantages of the TOS classification. It does mimic what we do in a clinical setting. It's based on only 3 variables that are used by physicians: the clinical findings, that's the history and examination, the results of the brain imaging study, CT and or MRI, and the results of ancillary tests. That's what we do every day. It's relatively easy to use. The definitions have been modified as medical knowledge advances. For example, when we first started this research, mitral valve prolapse was thought to be an important cause of stroke in young adults. We now know it is not, and so the importance of mitral valve prolapse has really dropped. You can change subtype diagnoses as more information becomes available. So you can work on the assumption that it is a cryptogenic stroke, but then after monitoring for 3 months, you find a high rate of recurrent atrial fibrillation. You can go back and say, aha, this stroke was probably cardioembolic origin. Next slide. Now, there are criticisms of toast, and some people have said that it should be burned. It's not relevant for stroke in children. That is absolutely true. The category of stroke of other causes mixes two subgroups, the prothrombotic disorders and the non-atherosclerotic diseases. That is also true. And if you want to separate those out, that's fine. Combining a wide range of cardiac diseases into a single category of cardioembolism also is problematic. But you'll find out that other than atrial fibrillation, most of the other cardiac conditions associated with thromboembolism to the brain are relatively uncommon. And you start getting very small cells of numbers of patients in these various subcategories. If you want to do that, please feel free to do so, but you're going to end up with some problems. Next slide. Now, the TOES classification does not work in an emergency department. We tried this. Why? Because the ancillary diagnostic studies are not available. So don't use TOES classification as a criterion for recruitment or as an indication for stroke treatment. Just this is an outcome measure that should be done several days or so after you've determined the acute treatment. This is planning for long-term care. Next slide. Now, if you really follow the stroke of undetermined cause, you get a large group, maybe a third of all patients. Now, researchers, physicians, the public don't like it. There are three groups lumped together and they may differ. That is true. The category of stroke to large artery atherosclerosis is the hardest to diagnose because it requires an ipsilateral stenosis greater than 50%. That number came from the carotid endarterectomy trials, which showed that carotid endarterectomy was effective only in patients who had stenosis greater than 50%. The fractured plaque, mild narrowing, and some of the other things that now are being looked at in the ESIS studies have shown that it is there. Next slide. Now, there have been things that have come since that time. A et al. In Boston came up with a system called the causative classification system, which is computer-based, and you can go to it, and it's really very slick. It has added a subdivision of evident, and it's added aortic disease to the cardioembolic group. That seems very reasonable. It did reduce the number of cases of stroke of undetermined cause. And I would encourage you to consider this classification system because it's available on computers and you can use it very easily. Next slide. The ASCOD classification came along about 10 years ago. This was aimed at avoiding the category of stroke of undetermined etiology. ASCOD stood for A for atherosclerosis, S for small vessel disease, C cardiac pathology, O other causes, and D dissection. So if you look at the categories, they're basically the same as in the TOES studies, and the definitions are there. One of the issues now is you have degrees of likelihood. One being most likely to be associated with it, all the way down to no absence of the disease or insufficient workup. This leads to a large number of potential conflicts. And frankly, I don't think the Ascot classification has gained much traction in the last decade. I know Amarenko and his colleagues in Europe use it, but I'm not sure it has really pushed the whole field of stroke subtyping to a better level. Next slide. So the stroke of undetermined etiology, that has been considered to be a weakness of the TOS classification. That actually may be a strength, because this has allowed cryptogenic strokes to be assumed to be secondary to embolization, and went on to look at new strategies to prevent recurrent stroke in this area, looking at variety of cardiac diseases. There's a study looking at atrial cardiopathy, diseases of the aorta, moderate changes in the carotid arteries, and they have used the new interventions and have used new diagnostic studies. Next slide. The stroke of undetermined etiology was looked at in the UK. You can see that death and dependency at 6 months was the same for all the patients with stroke of undetermined etiology as it was in those patients who had stroke other than secondary to cardioembolism. They had fewer atherosclerotic risk factors. There was no increase in coronary artery disease or carotid disease, and no increase in proximal AF. So there have been looking at ideas of how to work on stroke of undetermined etiology or cryptogenic stroke. This is still an area that I think is open for a great deal of further research. Next slide. So the TOS classification has face validity and is useful clinically. The category of stroke of undetermined etiology has been criticized, but it in fact has served as a springboard for a whole new area of research in the area of cerebral embolism of undetermined cause. Despite valid criticisms, the classification system is used worldwide, and it remains an important component of your research in patients with ischemic stroke. Next slide. Now, to help expedite evaluation of patients with stroke and other neurologic diseases, NINDS has created a bank of common data elements. These include both clinical and ancillary assessments. These have been validated for clinical research and allows for comparison among studies. I encourage you to go to the NINDS common data elements. You'll find the things that I've talked about today, but other factors that may be very useful in your future clinical research. And NINDS is going to require that you include these elements in your research. Next slide. So we have a wide variety of instruments developed for clinical research in stroke. These are for acute care, rehabilitation, quality of life outcomes. Some are modality specific and others are more global. No single clinical instrument will address all aspects of patient stroke. By the way, these are Buffalo from South Dakota, my home state. Next slide. And final slide, number 2. Still, we have a quantitative element to a complex clinical situation. Stroke scales foster communication among healthcare professionals. These are used for clinical research, and they are extremely useful for both clinicians and researchers. And I encourage you to develop an understanding of the scales that you will use in your area of research in neurology. And I thank you for your attention, and we can have any discussion you guys would like. Thank you, Megan, for your help.
My pleasure. Thank you very much for your presentation.
Anybody, any questions, comments, snide remarks?
I actually had a question. Thanks so much. I can appreciate how complex it is to come up with a scale for a stroke. So for my proposal, I'll be studying cluster headache, which is a rare headache disorder, and there's not a formal validated scale. There is in in research aside from the headache diary. People will sometimes use scales that were developed for migraine. There is a more recent one for cluster headache. It's not officially validated, but I'd like to include it. Should I just explain why I'm using a quote unquote non-validated scale because it's the closest we have for a scale?
Well, I think you're going to end up having to do that. Cluster headache, I'm surprised there are not something more stereotypic like the amount of tearing or redness of the eye or frequency or severity is how they grade them. If they're not, I would then look at the migraine scales and see if they can be adapted to cluster.
And I think I kind of what I kind of skipped ahead. This is a scale that looks at the quality of life outcomes after treatment.
All right.
So that's one that has been modified going off of migraine ones because the same things like headache duration or headache impact are different, between cluster and migraine. So and so I think the one that is available is not validated, but pretty good.
Well, then you would have to explain where you're using that one. If there's one that's been used in other studies and it has been kind of accepted in the cluster headache research community, that's the one I would stick with. I would encourage you not to try to develop a new scale because you're just going to run into roadblocks.
Mm-hmm. Yeah.
All right. Any other questions, concerns? All right, everybody. Thank you for your attention. Have a good rest of the day and a great weekend. Bye-bye.
Bye. Thank you, Dr. Adams. Thank you, everyone, for joining. Our next webinar will be in 2 weeks on, Friday, May 30th. We look forward to seeing you then. Take care.